this station is called Return of the Living Dead, because we're gonna do some resuscitation. So, anyways, basically the reason for my station is just to talk through some of those emergencies that could happen. We never want them to happen, but we all know the reality is that they could happen. And so when you're not doing things very often, when you go to do them, it can feel very scary. Okay, so we're gonna run through two scenarios. The first one, I'm gonna just pick you guys, kind of do some scenarios of, let's have Laura, you're gonna be the nurse taking care of this patient, and Anne, we'll do you two first. So you are assisting, kind of like the charge nurse and all that stuff, okay? So 67-year-old male patient in PACU comes into PACU with Dr. Colleton and Ian. Status post right L5S1 microdiscectomy. So patient comes into PACU already awake, alert ×1, like still very sedate, still under anesthesia. Dr. Colleton gives his report, Ian gives his report, everything went well during the surgery, all's good in the hood. You get them connected to the monitor and you're going through, looking through the paperwork. I'm going to take the paperwork. We've got them all connected. We've got our vitals. Dr. Colleton does mention that the patient has a history of high blood pressure, back pain, high cholesterol, and a heart murmur. Okay, but he doesn't seem very concerned, said the patient behaved in the OR. This is very, very crazy. So, he, finishes his paperwork, all that stuff. Everything's good. You've got the patient sitting up. You're starting to give him something to drink, talk about pain, all of that stuff. Dr. Colleton says, you know what, he looks good. I've got to run up to Shady Grove on the 6th floor. I'll be around if you need me. I'll check back with you before I leave. And so he takes off. So it's just the two of you in PACU. And then all of a sudden you look over and your patient goes, and you look at the monitor and this is what you see. So Laura, what are your first steps?
Make sure he's responsive.
Okay, so he's not.
Yeah, seemed like he wasn't. And then call for help.
Okay, let's talk through calling for help. Let's just take a pause. What is calling for help look like?
I would yell at Anne and tell her that he's not responsive, and after I'm checking a pulse and doing all that stuff.
So he doesn't have a pulse.
Okay, and then listening for breath sounds at the same time, obviously doing the rapid assessment.
I wouldn't even bother with breath sounds. If he doesn't have a pulse, you're going to go straight to CPR. So you did all the right things. You called for help. You're feeling for a pulse. You're assessing your patient. If they don't have a pulse, we're just going to do quick jump on the chest, CPR. Anne's your accessory at this point. So now she's the one that's got a less tied into the patient. So she's going to assist with that calling because she can only do so much, right? So what else could you do to get more resources to you?
I'm gonna call code overhead.
Yeah. So how do we overhead page?
Isn't it 277003?
I wish it was just 55 like it used to be.
No. It's written on the phone.
That's all you need to know.
Okay.
Yeah.
It's written on the
So
phone.
it's written on the phone. So you pick up the phone. It says code, right? It says the number. So you pick up the phone, you dial what it says, and you say code blue to PACU. Code blue, PACU. All available resources to PACU. Hang up the phone. Who else could we call that said that they were running upstairs?
Dr. Cullen.
Dr. Colleton. I need you down here. Stat, the patient's in cardiac arrest.
Yeah.
Next, as people start coming, you can start giving people getting the core card. What can you tell me about this rhythm?
B10. Call 911 too.
Call 911. Have somebody from the front desk. You call 911. Tell them that we have a post-op patient in cardiac arrest. Stat. Code car, yes. What is going to resolve this potentially that we can
Happy.
do? Before that.
Defibrillator.
Yeah.
Yes. So, electricity, right? So we've got an adult patient in acute cardiac arrest. It's most likely due to a cardiac cause. Part of the BLS protocol is early CPR
Yeah.
and defibrillation. So, also another thing to be thinking of, as 5 million things are going on, you started CPR. We're 2 minutes in, right? You've got somebody that rushed and they're starting with ventilation, so you're getting into your rhythm with 30 to 2, but you're sweating up a storm and you are tired.
Yeah.
So
Gotta get
Esme
somebody
comes
else.
in, I can do CPR, let me know when you're ready to switch out. And you develop that plan of 2 minutes, next person, 2 minutes, next person.
Yeah.
Because you're gonna get so tired, you're not gonna be able to give effective CPR.
Yeah.
Also, if you're waiting to start CPR, you can be watching how good she's doing and evaluating. It looks like, make sure you're coming off the chest, right? So, oftentimes you'll see people, now they're
Yeah.
just deep in the chest. They're
Yeah.
not doing any sort of recoil.
Yeah.
Feeling for a pulse while you're doing CPR. I've got good pulses. All of those things
Yeah.
need to be done while you're evaluating. And then you have Ann or Pam comes up and you say, I need somebody to get him on the defibrillator. So Pam, give your packet to Ann and come show me how you're gonna do the defibrillator. I'm gonna tell you guys, in these scenarios, we're just gonna use AED, okay? We're not gonna screw around with defibrillating the patient. We don't have anesthesia around. The easiest thing is to stay with BLS. These are your pads, they're pediatric, but pretend they're adult, okay? All right, so and what are we gonna continue to do while Pam's hooking this up?
CPR.
So we're not gonna stop compressing while we're putting pads on, right? So the pads tell you right on them where they go. So you're gonna put the pads on, you're gonna actually,
Hook it up.
so hook it up to the actual cord. Show me that. You don't have to stick the stickies on. And I've made this a little bit easier for you guys today, but what is normally on when you're checking it every day?
The lock.
The lock. So before you can hook this up,
Oh, that comes off.
you have to take this off.
Okay.
Otherwise it doesn't work. So now, one other thing you're gonna be doing as you're doing this is you're gonna be turning it on, right? And with the door closed like that, it's already in AED mode, right? So it's gonna walk you through, connect the electrodes. They're connected, we're all connected. You're gonna push analyze, right? Do we have to stop CPR to analyze?
No.
No.
Continue.
So that used to be a thing. We used to have to stop to analyze. We don't have to stop to analyze anymore. So don't stop. Now it's saying shock advised, charging, ready. And
Clear
so
everybody.
the biggest thing in these circumstances is that everybody's kind of doing their own thing, right? So if you're doing CPR and you're the secondary person, you're going to be ending up taking control of the situation, pointing people in the direction, saying, Pam, set up to defibrillate the patient. And I'm going to expect for Pam to do closed loop communication. A shock is advised. Shock is advised. And what would what do you want to do next? All hands off the patient, shock, continue, resume CPR, okay? So until anesthesia gets down, focus on BLS. I don't think we have time. I mean, heaven forbid this happens in the middle of the night.
It does.
And that could totally be the fact, right? And Dr. Culleton and I have talked about this. You barely have enough hands to even do BLS because you have one person that's pushing on the chest, another person's calling, that other person's gonna have to go down and let in EMS.
Yeah.
This, just pound on the chest for all I care. I don't even care about you trying to get 2 ventilations in, especially if it's an adult patient. It's a cardiac issue. There is a lot of blood flow, oxygenated blood flow already in the body. Keep that pump going until somebody gets there. If you can connect the AED and get that going, heck yes. But don't worry about trying to do defibrillation, give medications, anything like that. Does that make sense?
Yeah.
Okay.
Call 911 as soon as possible at
Right.
nights.
Yes. Call 911.
Get help.
Get help. Exactly. Okay, but now.
the champions, my friends.
Okay, we can go sit down again. Okay, so Dr. Colton comes in and he's like, okay, Ann, give me an update. What's going on?
Well, our patient, we're continuing CPR. We've done the AED
Shocked.
We've shocked
Shocked.
once.
once.
Are they
And the
still in
patient-
Are they
VSAC?
still in?
Yes, and so Dr. Colton sees on the monitor, he says, oh, it looks like the patient's still in VTAC. I want to defibrillate the patient at 200 joules. So that means he wants to go out of AED mode. So show me how you're gonna go out of AED mode, Laura.
Connect electrodes.
Can we do this?
Yep,
And then energy select?
yep. So you're gonna pick your energy,
And there it is.
and then, yep, and then you're going to,
Charge it.
yep,
Connect.
and it won't do it, but once it's charged, it'll tell you, and then we're gonna say it's ready to
Clear.
go. Everybody all clear, shock, back on the chest, right? Okay, so we know how to do all of those things. We're just gonna change scenarios really quick, just so I can show you all the functionalities of this. So let's say a patient this different patient is in like SVT. So they're in an organized rhythm, but they're unstable, right? So they're hypotensive, we can't do vagal maneuvers, we've gotta go right to synchronized cardioversion. Why would we synchronize cardiovert versus just cardiovert?
Because they may be in atrial fib, for one thing.
Okay. What is the risk if we cardiovert somebody that has an organized rhythm?
You'll hit
Isn't it,
the T wave.
Yes. So if you hit the wrong part of the QRS, because this will it'll just shock wherever their heart is. It'll just shock, right? But if they have an organized rhythm and you hit the T wave, the end part of the QRS, you'll actually just put them into VFib or VTAC. You'll make them worse. So in those circumstances, we need to be very diligent to synchronize cardioverts. So these are people that are awake but unstable. You're gonna have anesthesia. You don't have to do this on your own, but they may ask you to do synchronizing. So if they want you to do that, you're gonna pick the energy, you're gonna hit the sync button, and you'll know for 2 reasons. The sync button is on, right? You see that illuminated? But also, you're gonna see with this rhythm here, there will be a hash mark that shows up on every QR, or every beginning of every QRS.
Yeah.
So you'll see that, and I've had it before where I had to synchronize somebody, and I was so scared that it wasn't on sync, but if you see those little hash marks, rest assured, it's
So
on
we'll only
synchronized
shock in the right spot.
spot, right. If you have a patient that you're doing this, they're awake, they're unstable, what's another thing we're probably gonna be doing?
Medication.
What kind of medication? Like why, I mean, yes, we might be giving like dysrhythmia medication, but we could also, my point in this is very uncomfortable, we're shocking the patient. So we might wanna give them a little bit of Versed or something, fentanyl, something like that. So that's another order that may, or you could be like, hey doctor, do you want to get a little Versed? Sorry, shock him? Because it's not fun. Okay, last thing I want to talk about with this monitor is if for some reason you needed to use it to pace the patient. So why would you have to do external pacing on a patient?
If their
The
heart
patient-
rate's 20.
So you've got a very low heart rate, it's not responding to medication, the patient's unstable. In this case, the pads need to be on the front and the back, right over like the heart. And also the defibrillator has cardiac monitors. So these have to be in place too. Same stickers as we use in PACU. But it can be confusing because when you have a sick patient and everybody's trying to figure out what to do, you can't figure out why it won't work. It's because these aren't attached. And you probably have your cardiac monitor leads on from PACU, but you need to switch over to these, okay? And then with pacing a patient, there's two things. The rate is determined by us. So whatever the doctor says for the rate, you're going to turn on the pacer pad, you're going to change the rate here, it would let you do that here. And then you're gonna start at a low voltage, which is under the current. And as you start to pace, the doctor's gonna be looking for capture. So you'll see the little pace in here, and then you'll want the QRS to follow it. So if it's not following it, then you slowly dial that up until you get capture. This all might sound very foreign to you. I just don't want it to be completely foreign, that you don't recognize that we have the supplies to do this if we need to. Typically, EMS is gonna get here before any of that happens. Questions, comments, concerns? Okay, all right, so that's the defibrillator. We have two different defibrillators and they're completely different. So this was the one on the adult code card. We also have a defibrillator on the pediatric code card, and it's very easy to use as well. And if for some reason that wasn't working, you could use this one. They both work for adult and pediatric is what I'm trying to say. As of right now, you guys saw my message. We only have pediatric pads on the pediatric cart, and we only have adult pads on the adult cart. The important things to know is that a couple things. Pediatric pads are only used up until 15 kilos. Once they get past 15 kilos, regardless of if they're still a kid, which we all know we take care of a lot of kids that are above 15 kilos, we use adult pads for those patients. So if you have a patient that codes in PACU, pediatric patient, you wheel this in and you're like, oh, I gotta get them on the peds pads. Make sure that they're under 15 kilos, first of all, because otherwise, bring this guy in there, hook him up, or use adult pads on this. So the other part to this is to use the pediatric pads on this. Did you know that you actually have to change the cable? So the peds pads are in here with the peds cable. So you actually have to change out the actual cable, which you do down here by turning this guy, this green guy, and pulling this out. You wanna come feel it, Ian? Come over here.
Yeah.
So see how there's a white thing right here and there's a white thing right here? You have to align those two things and push it in, but try to undo it. Yes, you have to twist it. Same thing with this one when you put it in. Laura, do you wanna come try?
So tell me about the cable again, I didn't quite get that. Why isn't that on there in the first place?
Because we can't test it with this.
Oh,
Yeah. So, and you guys feel free to do that whenever, but that's available to you. So just a couple things about the defibrillator. This guy, AED mode, you switch it here and it'll walk you through. It's pretty easy to explain. So it tells you exactly what to do. If you're doing defibrillator mode and the doctor's giving you joules that he wants to use, then you're gonna select the joules here. And then if you wanna do sync, if you're here, there's a sync button on and off. And then if you go to manual mode, you can use the pacer, which same thing, you need the EKGs on. And then you hit pacer and you can change the rate and you can change the output. Make sense?
Yeah.
Okay. So that's our first scenario. Oh, one more piece to that. So let's say Dr. Culleton's here, we've defibrillated the patient, we are talking about going down the ACLS algorithm. The other piece to assigning roles is making sure that you assign a recording person. We have new forms and they're very nice, so check them out. So it's not the first time you're looking at them when you're trying to fill one out. So Dr. Colton wants, he gets the survey of what has, or the conclusion of what's going on. We defibrillate. Now he said, has anybody given any epi? No, we haven't given any epi. So we have a medication nurse. We're gonna assign somebody to do medication. So the medication nurse pulls out the epi and realizes, I think when they were doing CPR, somebody pulled out the IV. Okay. So what are we gonna do? We need access and we need it quick.
Is the patient tubed?
No, we're just still trying to ventilate. They have an oral airway in. They're ventilating the patient. What are we gonna do to get quick access?
IO?
IO. So where do we keep our IO? Yes.
On the bottom.
So this is what it's in here. This is the code or the IO kit. And when you open it up, you'll find the drill in its little holster. This is the drill. It's got a little protector thing over it. So you actually have to remove that, otherwise you're not gonna have a lot of success. Feel free to try it out there. And then all these packets are gonna
Well,
fall
here.
on the ground
Try it out.
and you're gonna be like, what's going on? I don't know what to do. So there's 3 different sizes. There's the pediatric size and it's the length of the needle, not the width. So take a look at the length of that. And then the blue one is for the majority of all humans, adult size. We do have a larger one. This is for our morbidly obese patients or even somebody that has a lot of muscle tissue. Like if you know that you're gonna be going through more than just bone. You can also use this larger needle for regular sized people. It actually has different lines here. And so when you put it in, it'll make a noise. It'll go, and then you'll know it seats into where it needs to be, and you don't need to go any further. So if it lands here, you're fine. You can still use it. Does that make sense?
Mm-hmm.
What are the 2 areas that we can put in IOs?
And then below the knee.
Chris.
Tibial plateau. Anybody have another? There's 2 places.
I don't know.
Humeral head. So when I got familiar with these in the ER, we used to have the jam sheeties. If anybody remembers jam sheeties, but you have to like put them in like this
Manually?
I was always told tibial plateau. And then when they introduced this humeral head, it scared me because it's like we're doing chest compressions, their arms move. I'm just a little worried about this. I don't like it. And so I always went to I felt like the tibial plateau was good too because you're doing a lot, right? But you could easily come in and put this in and get it hooked up and call it a day, right? Well, I went to an amazing conference where I got to participate in hands-on skills with a cadaver. And so I was able to drill and put in one into the humeral head and then infuse fluid. And I got to watch it go into the subclavicular vein into the heart immediately. It was just like you flushed it like an IV. It just went right into the heart. And so it really sold me on how easy it is to put this in and use it for, a cardiac arrest situation. We're not putting these in alive patients, right? But if you did, you'd be surprised. It does not hurt to put the needle in, or it's like an IV. What hurts is when you start to infuse fluid. And so if you ever did this on a patient that was awake, you would put a little bit of lidocaine in before you start putting fluid in. So tibial plateau, that's that area on your knee, that right below your knee, and then medial where it's flat. So like right in there. Yep, like right there. So right here. Okay? Humeral head, you know, there is a lot of muscle and tissue there, but you can easily, I put them in and you'd be surprised at how easy they are to go in. So you're going to connect your drill to your needle like this, and you're gonna hold this down, otherwise it'll come off, right? So you're gonna hold this down, pull this out, bless you. And then you're gonna prep the site like you would prep for an IV. Okay, so just chlorhexidine, whatever. You're gonna get it, you're going to push down, but not hard. Just push down a little bit while you point the drill, and you're gonna hear it go, and it goes in, and then it seats. It sits in there, and it's kind of like, and you know you're there. This is typically right at the tissue, the skin, but not always, like I said. So once you get down, you take this part out. It also comes with this guy, which is a dressing for it. So if you see, this just goes right over here, like this. Oh, I'm sorry, let me do one thing first. So you've got this in, and just like an IV catheter where there's a needle in the center of it, this is the same thing. So you unscrew it. So this comes out, and there's actually a little sharps thing. So this is for your sharps, you put it in there. And so this is what's left, like this on the skin. And then you put it in like that, it hooks into place, you pull out these pieces, and the plastic sits onto the patient. So it's not gonna go anywhere. So it also comes with a flush. So or a saline lock. So you're gonna take a 10 cc saline syringe. You're gonna flush some saline into here, and then you're gonna attach it onto here. It just screws on. And then you're gonna connect a normal bag of saline once you get through the prison gates. And now you do have to push a little bit with this, so we use pressure bags. Are you guys familiar with how to use the pressure bags? So you've got it attached. I would just take the 10 cc syringe when you're at this point and push. Make sure you don't see fluid around the site. That's one thing that I have seen if it's not in right. So if you use a tiny little needle, it doesn't go in. Sometimes if it's a pediatric patient and you do it too forcefully, you can go all the way through. You don't want to do that. But if the patient doesn't have a pulse, this is the least of your concerns.
Yeah.
If it doesn't work, you just move on to the other leg or the other arm, okay? Don't freak out about it, okay? So you hook it up, you've got your pressure bag, fluids are running in, and now you can give your epi. You can give whatever medication you need to give through this. Questions? Okay, that's a lot. Also, just so I'm picking on you guys because you're the PACU nurses, so you get to hear all of this spiel. But just so you know, on the code card, and Anne could probably tell you this in her sleep because she's the one that maintains the code card, but we have so many things on here. So say somebody comes running out of the OR and they say the anesthesiologist created a pneumo, or the surgeon created a pneumo. We need a pneumo kit. We have those things on this card. So there's two different pneumo. First of all, this is a triple lumen catheter, so we can put it in a central line. I don't know when we'd ever do that. This is the quick pneumo kit. So they can just put in a little flutter valve. So if they're looking for that, that's where it is. If they need to actually put in a chest tube, there are chest tubes down here.
Yeah.
And I didn't know this, but did you know that there's needles in here? Or there's like a sharp part to it, so you can actually use it to cut. And so the only other part that Dr. Colton said he needs is that baggie.
That bag.
Yeah. There's a trach kit in here. That's a bad day. When would we need to do a trach? if all of a sudden we have an laryngospasm that nobody can break. So just good things to know. We have blood tubing in here, but the majority of the blood tubing we're gonna find. Give us about 20 minutes.
Okay, I gotta visit CJ.
There you go. So anyways, most of the blood tubing is in the OR with the blood transfusion stuff. Okay? I can't remember if we talked about it or not, but the backboard, yes, for CPR. We want to make sure we're getting adequate CPR. Okay, so that's the adult situation. Next up, next scenario. So this scenario is going to be Esme and Pam. Pam, you get to take care of a kid.
Well, okay.
She loves it.
Okay, so second scenario. You're hanging out in PACU, somebody's like, Pam, there's nobody else. You have to take this 4-year-old. So you're ready. It's a 4-year-old female patient coming out of PACU, status post TNA, okay? The patient is still asleep and the PACU nurse, Pam, is taking a report. Esme, you're the secondary, okay? Anesthesia is giving you report, all vitals are stable, you've got the patient hooked up to the monitor, pulse ox, you've got the anesthesia mask kind of just hanging out, the patient's still got an airway in, an oral airway that is, and all things are good in the hood. Anesthesia moves on, they go to pre-op, and they're pre-oping their next patient, okay? The next thing you note, the patient kind of coughs a little bit and the airway comes out. You think the patient's starting to wake up. But all of a sudden you notice that the patient's sats start to drop a little bit. Oh, and did I mention, anesthesia also tells you that the patient had a recent respiratory infection and has a history of asthma. So sats start to drop and there's decreased air movement. So you see all those intercostal muscles kind of going in and not a lot is happening down here. You hear the patient going, okay? What are going to be your first steps?
First, make sure their airway's open
And how are you going to do that?
on a kid. Well, tip the chin.
Tip the chin. Typically, if we're thinking laryngeal, and that would be probably my first bet too. If we're kind of going down the laryngospasm pathway, the best way to open the airway is a jaw thrust. So, I would reach out for help, right? So help. Esme, can you get me some help in here? Can you go find the anesthesia? If you can't find the anesthesia, you're overhead paging.
I'll help to ice.
Yes.
He's
I see you. Yeah.
That's just automatic.
You went to your. So I'm gonna pass these out to you guys, and then we're gonna play a little video.
Thank you.
I'll take the code thing from you
Oh, but put them on CPAP, huh?
if we need to. Okay, so this is a 6-minute video. I'm gonna walk away, so if somebody wants to sit here, go feel free. Like Esme, if you want to get closer, you can watch.
One of the more frightening events in anesthesia is laryngospasm, the protective reflex spasmodic closure of the vocal cords that occurs when the vocal cords are stimulated. In laryngospasm, vocal cord closure can be so forceful that it can prevent ventilation or even the passage of an endotracheal tube. Avoiding vocal cord stimulation when the level of anesthesia is light can usually prevent laryngospasm. However, laryngospasm can occur even in the best of care, especially in patients with irritable airways such as those with asthma, COPD, smokers, and those with upper or lower respiratory infection. Complications include life-threatening hypoxia, post-obstructive pulmonary edema, and even cardiac arrest. A quick review of laryngeal muscle movements will help us understand why laryngospasm prevents ventilation. There are 3 major types of movement. Movements affecting tension of the vocal cords, movements swinging the vocal cords open and closed, and movements that close off and protect the larynx. Movement affecting vocal cord tension, like the pitch of the voice, occurs by rocking the thyroid cartilage forward and backward on the cricoid cartilage at the cricothyroid joint. Watch the tension in the vocal cords as this person changes pitch to appreciate the dynamic muscle control.
And take a breath.
Movements that swing the vocal cords open or closed occur by swiveling the arytenoid cartilages on the back of the cricoid cartilage. Our vocal cords pivot constantly during the breathing cycle, opening more widely during inhalation to minimize resistance to breathing. Movements that close off the top of the larynx protect it during swallowing or from aspiration. Muscles that surround the outside of the larynx, called extrinsic muscles, move the larynx up and down within the neck to support this function. For example, during inhalation, the entire larynx falls in the neck, a movement that pulls the epiglottis up and away from the glottis, further opening the airway. During coughing and swallowing, the larynx rises in the neck. This higher position causes the epiglottis and the back of the tongue to drop downward over the glottis, closing it off. Laryngospasm consists of the combination of all of these different types of muscle movement. This is a typical view of the larynx during intubation. Here you can see the curved epiglottis above, the bulges of the arytenoids below. The triangular gap between the vocal cords is called the glottis. Above and to the sides of the true vocal cords are the false vocal cords. Look how close the esophagus is to the larynx. This larynx is about to go into laryngospasm, caused by touching the left arytenoid with the tip of the endotracheal tube in a patient who was too lightly anesthetized. Note the dynamic closure of the vocal cords, the closure of the false cords, the mounding of the paraglottic tissues by elevation of the larynx, and the folding of the epiglottis over the glottic opening. When you see laryngospasm, don't force the endotracheal tube through the glottis because you could traumatize the larynx. Instead, stop and break the laryngospasm. This patient's laryngospasm broke quickly with positive pressure ventilation and deepening his anesthetic. Let's look at techniques to break laryngospasm using positive pressure in this staged recreation. To break laryngospasm, stop stimulating the vocal cords. Direct all efforts to delivering oxygen. Ask for help. Once triggered in a semi-conscious patient, laryngospasm often persists for a dangerously long time because the part of the brain that would normally turn it off is effectively asleep. Hypoxia, potentially leading to cardiac arrest, can develop quickly if the spasm isn't broken. Apply your ventilation mask tightly against the face and provide forceful positive pressure breaths with your ventilation bag while performing a jaw thrust. The jaw thrust is important. Thrusting the jaw forward lifts the epiglottis and tongue off the glottic opening, rocks the larynx forward, counteracting some of the tension bunching the cords together, pulls on the aryepiglottic folds, which connect the sides of the epiglottis to the back of the arytenoids, opening a small gap between the vocal cords, and stimulates the patient because it's painful, perhaps awakening the patient out of stage 2 towards consciousness. You may need someone to squeeze the bag while you perform a jaw thrust. All of these actions are directed at creating a gap between the vocal cords. Once you have that gap, then the positive pressure breath forces oxygen below the cords. This pressurizes that space and forces the cords further apart. You must have a tight mask seal for this to work. Positive pressure plus jaw thrust usually, though not always, breaks the spasm. If the spasm doesn't break, you may need to give a small dose of sedative or muscle relaxant. Be prepared to support ventilation. Prevention is better than treatment. To prevent laryngospasm, avoid stimulating the vocal cords in a semi-conscious patient. Ensure the pharynx is clear of secretions, especially before extubation. Extubate either awake or in a deep plane of anesthesia, not during the semi-conscious anesthesia stage 2. Be vigilant Be prepared and react quickly if it occurs, and never hesitate to ask for help.
Awesome. All right, what do you guys think of the video?
Good.
Good, good to see.
Yeah, I like it just because it shows really well what's going on, and so you can kind of understand the physiological, pathophysiological understanding of what's going on when this is happening. And the takeaways, obviously, there's stuff we're not going to be intubating, all that stuff. However, there are two things that we can really hone in on, and that is opening the airway effectively and providing positive pressure ventilation. So the thing that I want to talk through just a bit with you guys, so like we talked about, Pam, head tilt chin lift works a lot of the times. In these patients, it's not necessarily effective. And what is effective is using some pressure and force at the angle of the jaw forward. And if you put your thumbs back there and you push forward, you can feel, I'm gonna do it to you guys. Don't hit me. So,
Yeah, that's not comfortable.
no, it's not comfortable. There, come here. She's like, oh. But you feel how your
Yes.
jaw just went forward?
Yes.
So not only are you opening the airway and actually getting that airway open without so if you do this, you might be protruding the tongue more into
Like
the
pushing.
airway. Or if you're doing this, you're pushing all that tissue into that space. Whereas if you're just doing this, you're just forcing the airway open, and that stimulation can actually force them out of that stage 2 into a more awake state where their vocal cords are opening. So it's a win-win. First and foremost, if you're doing this and you're like, okay, here we go, we're getting into this, move the bed out, unlock the bed, get behind the patient so you can have both arms. Have two people, one's opening the airway, one's trying to ventilate. When we get the patient in PACU and they have that anesthesia mask, they come out with that oxygen, that might be enough, right? It might be enough just to focus on opening the airway where we don't have to ventilate. But if it's not working and you're not getting them, you don't open the airway and see that ventilation start, then you might have to move towards using the anesthesia bag or a BVM, right? So what works for me, and everybody's a little bit different, but you need to push down on the mask to get a good seal just as much as you're pulling up on the jaw. So I put my thumbs like this, and that helps to keep that down. And then I'm taking usually it's my middle fingers at the angle of the jaw to pull up. And now I've got a tight seal. So now, Anne, if you want to come over and help me ventilate the patient. And now, what are we looking? Go ahead and connect it.
Chest rise.
Okay, so we're seeing chest rise, right? So, and if you don't be hesitant to readjust. You're like, oh, I'm feeling some air coming out here, or gosh, maybe I am not pulling up hard enough. So adjust and make sure not only are you getting good chest rise and fall, but you're looking over at your monitor, and what are you looking for?
Chest rising.
Your sats.
That their sats are coming up. So the one that we had, Paul and I, the sats were in the 40s. And anesthesia came in and she was doing just what we're doing right now, except for she wasn't actually ventilating. She was just doing the airway and forcing the mask to make sure it was on there. And we were watching those sats slowly climbing up and watching the chest. Yeah, it was Fox. So I think so easily, and I want you guys all to get in here and practice. So Anne, you can practice the airway, and then Laura, you can practice. I know.
Was it a pediatric patient you were talking about? So I have a question.